All right. Hello, everyone. Welcome to this University of Toronto event entitled Current Trends in Pathology, a discussion with alumni on this extra special International Pathology Day. My name is Anjelica Hodgson. I'm a gynecologic pathologist at Toronto General Hospital University Health Network, and I'm an assistant professor in the Department of Laboratory Medicine and Pathobiology at U of T. And it's my pleasure to moderate today's session. Before starting, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the land which we call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We are going to begin the event with self-introductions from our three panelists, and then we will work to address some of the questions that were submitted during the registration process. And then we will end with additional questions from the audience. So please enter your questions and comments in the chat box, and we will do our best to address those beginning around the 6:30 p.m. mark. And a reminder to the audience just to keep yourselves muted to decrease any background noise. And let's move forward with meeting our panelists. So first, Dr. Kona Williams.
All right, good evening, everybody, and thank you for this. Thank you for inviting me. My name is Kona. I am Cree and Mohawk. My dad was Cree from Peguis First Nation out in Manitoba. My mom's Mohawk from Ganawage. And so it's just fitting that I live somewhere in between. I am joining you guys from Sudbury in Northern Ontario, although it's not that far north from Toronto. It's about 4 hours. I am a forensic pathologist. So yeah, I do autopsies. I determine cause of death. And I mean, I'm busy, but it's a good busy. I really enjoy what I do, and it was a long haul. It was an interesting journey that I had. I did my undergrad out in Halifax in Nova Scotia, and my whole dream was to be a PhD research scientist and hang out in the lab all day long, because that was like my favorite place to be. And then I guess my grades were good and I got encouraged, say, hey, do you want to go to medical school? And I just thought to myself, well, pre-meds are crazy. Like, have you seen them? Well, okay, fine, I'll give it a shot, see what happens. And so I applied and I ended up getting in everywhere, which was a huge shock to me. And then figured, okay, off I go to medical school. So I went to the University of Ottawa. My now husband, his family's there. So it just sort of made sense to have that support system. And yeah, then I decided to stay there for residency as well. And during that, the whole system changed in forensic pathology. This whole thing called the Gouge Inquiry and Charles Smith happened, and they brought in forensic pathologists, so trained forensic pathologists, and started up a regional unit in Ottawa. And that was very early on in my residency training, and I got to meet these fantastic people and get trained and learn from them, and decided, yep, this is what I want to do for the rest of my life. And so telling that to my family, specifically my dad, who was like more school. I'm like, yes, Dad. He's like, but when am I going to stop telling people that you're in grade 33? And so the other thing he had a concern with is dead people. Like, really? I'm like, Dad, like this is what I want to do. So that's where my journey at UT started. And that's when I joined as a fellow and spent my year training at that brand new facility. Me and another fellow, we were both trained there. I think we were the first fellows who trained there. And it was like, I was like a kid in a candy store. It was awesome. Stayed there for a few years, and then found myself up here in Northern Ontario and sort of serving the population that I think I was always meant to. And now I've kind of graduated into serving people more on a national scale, but I can get into that afterwards. So thank you.
Awesome. Dr. Gino Somers.
Hi, Angelica. Thanks again, everyone, for inviting me to speak today. I'm really excited. I started off my medical school in Melbourne at a university called Monash University, and did, during my medical school training, did 12 months of research into IVF, in vitro fertilization. And that really gave me an interest to do research as part of medicine. And when I came out of medical school, I did 2 years of surgical training, because back then in Australia, when you graduated from medical school, it was expected that you do 2 years of clinical work before you decide on a specialty. And I did 2 years of predominantly surgical training. And while I loved the surgery and the technical part of it, and actually going in and, you know, fixing people with your hands, I realized pretty quickly that I was more interested in the clinico-pathologic meetings we had with the pathologists. So I switched very quickly to pathology, got into a program, and trained at the Royal College of Pathologists of Australia for 5 years. Same time, I did my PhD in molecular path, and came out here for a 12-month fellowship at Sick Kids, with the idea of going back to the Royal Children's, bringing everything I learned and setting up practice in Melbourne at the premier children's hospital of Australia. Well, obviously I didn't do that, because I'm still here. Wow. Next year it'll be 20 years in Canada. It's just gone in the blink of an eye. It's incredible. So yeah, I stayed here. I became staff. I did a lot of my early and mid sort of career academic activities were focused on sarcomas, molecular pathology, and I morphed more into test development, you know, as I got more into my mid-career, because I sort of felt that that was a good fit for what I was doing at Sick Kids. Once I sort of moved into medical leadership in 2013, I got really interested in you know, medical leadership, health leadership, and, you know, how best to serve the people that you lead, because it is something that I think is really important to get right. You know, you're there as a leader, you're there to serve people, and it's such a privilege to be able to do that. So I've held a few leadership roles over the last few years. My last one was I was president of the Society for Pediatric Pathology, and I was, you know, given the presidency literally 3 days before COVID was declared a pandemic and everything kind of shut down. So at the end of my 12 months, I wrote a little piece and I titled it President in Exile, which I kind of felt like I was, because I couldn't travel. It was literally being president from my desk, which was kind of convenient, but it wasn't quite how I pictured it. Right now, I'm interim chief of labs at Sick Kids. I'm a pediatric pathologist, and I am a professor at the University of Toronto. And I'm doing a lot of work in wellness and well-being. And again, it fits really well with my leadership roles. So thank you very much, Angelica.
Great. And Dr. Andrew Evans.
Okay, thanks, Angelica. It's a pleasure to be here with you this evening. So my life story, I guess, can be summarized as follows. I was born in Toronto, grew up in London, Ontario, did undergraduate at Western University, then known as University of Western Ontario. And then from there, did a PhD in biochemistry at Western. And then when it came time to finish up the PhD, I was looking for sort of next things to do, and is it more school? So just like Kona, I did get questions from friends and family, like when have you had enough school? So I decided to go to medical school. I went to the University of Toronto, graduated from med school in 1995. And then towards the end of medical school, what do I do next? What do I want to do with myself? And with the training in biochemistry, I was initially interested actually in internal medicine and endocrinology. That was the area that I had been doing research in lipid metabolism in particular. and did a few electives in medical school and endocrinology, and quite frankly, thought I might get bored doing it. And then did one elective in surgical pathology, which was at a community hospital, where it was actually tied to a surgeon in the morning, scrubbed into surgical cases, and then followed specimens out of the OR into the pathology lab, and then followed cases along if there were intraoperative consultations or frozen sections, etc. And I really got a chance to see what pathologists do. And I was quite taken by the diversity of the specialty. And that was the one thing where I thought right then and there, there's no way I would get bored if I did this. And so from there, did a couple of other electives in pathology, and the rest is history. So from there, I did an anatomic pathology residency at U of T, graduated, and then went in to do a fellowship in genitourinary pathology at University Health Network, then the Toronto Hospital, it was known as. And then from there became staff and toiled at the place where Anjelica is working now for close to 20 years as a genitourinary pathologist. And during that time, I got the opportunity to take a leadership role in implementing digital pathology for patient care. So this started way back in 2004. And now it's something that is catching the interest of a lot of different institutions, but back then we were really quite unique in doing that. And in fact, most pathologists were not comfortable at all with doing anything that didn't involve glass slides and a microscope. And so UHN had really, blazed the trail there, and it was a tremendous opportunity. In terms of my academic career, it's really followed. I would describe it as follows. It would split between genitourinary pathology, where I've been involved in a lot of guideline development, best practice development for uro-oncology, best practice guidelines, etc., as well as tremendous opportunities for translational research at UHN with a very busy uro-oncology group there. And then the other side would be the digital pathology. And that's really, I've literally been able to travel the world because of that experience. And sharing, experience with digital pathology and implementing it for patient care with academic and community hospitals literally around the world. So it's been a tremendous opportunity that way. And then I've also been involved extensively with the College of American Pathologists in guideline development and best practice development for digital pathology, and now machine learning and artificial intelligence. So this, has really been sort of the gift that keeps on giving. Since I moved from UHN to Mackenzie Health in August of 2020, became the chief of lab medicine and pathology and medical director of lab medicine, rather. And this hospital is the first in Canada to become completely digital. There are others that are working their way toward it, but as a relatively small hospital of just a group of 8 pathologists, it's been extremely relatively easy compared to where I was before to advance digital pathology and get pathologists to embrace using it, and to set the stage for developing digital pathology consultation networks. I see Dr. Kendall is on the call tonight, and we're working actively on a project to link Mount Sinai and Mackenzie Health as a proof of concept. And then hopefully that will pave the way for a whole network that will follow. And then we've also, because we are completely digital for surgical pathology applications, we can now start evaluating some artificial intelligence tools, which I literally just started to work with last week. So that's basically it for me.
Great. Thank you to the 3 of you. So I think we'll get started with some of the questions that were submitted in advance. And the first one is a foundational one, to Kona first. Why did you choose pathology?
Yeah, that's a question I think a lot of my family are still kind of asking. Because it's not something that I find a lot of medical students. It's not like they go into medical school thinking, oh, yay, I want to be a gung-ho pathologist. It's like, who's that person talking about dysplasia? What is that? And it's really unfortunate because it's just such a fascinating specialty. And I mean, considering going way back to when like I wanted to be PhD research scientist and have my own lab, I actually have come full circle because now I am the medical director for the tertiary care center here, and I do have my own lab. They don't actually let me touch anything in there because I'm one of those people who likes to push buttons and turn things and pull things. And so if there's something that if I get that little itch, they'll put me in a corner with something that's being like refurbished and go push all the buttons you want. But it was really serendipity, I think. There's no doctors in my family. There's nobody who even has a degree in science. So I was a real oddball. And going to medical school, like I didn't even really know much about like residency. I had nobody to tell me any of this stuff. And this was, I mean, I had some internet sources, but it wasn't that great. It's not like today. And so one of the first people I met was a pathologist, and she was such a good teacher. The very beginning stages when you're getting like this fire hose of information at you like every single day. And this sweet, unassuming woman got up and just said, I want you to know 3 things. And she says, I want you to know metaplasia, dysplasia, anaplasia. And if you can get that out of this lecture, that's great. And the way she taught was so engaging and so interesting. And she made it so simple that I went to ask her, like, well, what are you? Like, what do you do? She says, I'm a pathologist. And I just stared at her like, I don't even know what that is. So that was sort of the slow introduction to pathology. We did have elective time, so I spent a lot of time hanging out in the pathology department while, some of my other classmates were off like, running codes in the emerge or like doing suturing. And I'm like, wow, guys, I saw a teratoma. And they're just looking at me like, ew. I'm like, no, it wasn't ew. It was really, really cool. And of course, I looked at other things like anesthesia was really fun for a while, and surgery was great as a med student, maybe not so much as a resident. In different areas, I try to get as much out of each rotation as I could and learn as much as I could. Because again, I had no idea what I wanted to do, but I kept getting pulled back to pathology. And I think I'm one of those people that just likes the answer to things. And, lo and behold, there aren't always answers in pathology, certainly not always answers in forensic pathology. But I liked that idea of, okay, so everything that happens to that patient is a result of the diagnosis that I make. If I say this is cancer, then surgery, chemo, all that follow-up, everything happens because then they're waiting for that diagnosis. So that to me was a very exciting thing, a very challenging thing, and a very humbling thing because the responsibility is enormous. And so it just sort of fell naturally. Okay, I will admit I was really seriously flirting with radiology, but again, the 2 specialties are fairly similar. They're both very visual. But I found, although radiology is like really sexy and fun, and my radiology friend makes like 5 times what I make, I just like the answer. Like, they say, okay, well, it looks like a cancer, but pathology will figure that out. Well, I wanted to be the person to figure that out. That was sort of my drive. And then, yeah, like, it's just, I find it such a fascinating specialty. And, I was like thinking about it, like what do I want my life to look like? Do I want to be in the hospital on call every night or every other night? Do I want to be run into the ground by the time I'm 50? Or do I want to be able to feel excited every morning and thinking, what am I going to see this day? I do like my alone time. I'm not horrifically introverted, but I'm fairly introverted. But I mean, I have my office, I've got my jungle, my little zoo in there. I've got fish, I got plants, I got like little dart frogs. I've got a walking treadmill, and I can just, if I need to, and if I need a break, go to my office. I can walk on my treadmill, do my reporting, have my meetings and just listen to like 90s dance music as much as I want, and nobody bothers me, which is great. So that's sort of, again, it was serendipity and a combination of really good teachers and really good mentors. And I think that's so fundamental for medical students when they're looking at different specialties or looking at what it is that they might want to do. I find that the people who are who have the most influence are the good teachers and the good mentors out there. So for any of the medical students out there who are still unsure, that's, if you find one of those people, like, don't be afraid, go latch on, go walk down and ask them, what the heck do you do? And you never know where you might end up. So that's kind of how I ended up here.
Yeah, mentors and teachers are so influential, especially for our specialty when, as you alluded to, there's not really that much exposure for people that are starting off. Andy, how about you?
Well, in terms of my journey, I think I did summarize it at during my introduction. And Kona, you reminded me of something once, that a friend of mine who's a radiation oncologist came up to me at a conference and said, you know, it seems you can make a television show or movies, but particularly TV shows, you can make them about emerge docs, about surgeons, trauma surgeons, and pathologists, but you can't make a TV show about a radiation oncologist. Yeah, you're absolutely right.
Yeah.
So, and most people think, I mean, I did, my wife is a high school teacher, and I had been over the years, I've been to career days and things at the various schools that she's been teaching at, and just explained what a pathologist does. And usually I start out by asking the students what they think a pathologist does. And invariably they say, oh, you figure out how people died. And so they usually go straight to forensics because that's what they see on television. And then, so I'll explain, yes, okay, that's one of the things that that pathologists do. It's a very important part, but the part of pathology that I practice is surgical pathology, and we don't do any autopsy pathology anymore, but I did for a time when I was at UHN, but it was all medical autopsies. And so then I would explain what I did as a surgical pathologist and then open it up for questions. And invariably the questions from the students came back as, what was the most interesting or bizarre thing you've ever seen in an autopsy? So.
And what is it?
So for me, I think most of them I probably wouldn't explain what I saw, but during my time, my residency at residency training at the forensic in forensic pathology, which was then located right downtown on Grenville, and I saw some interesting things there. Well, things which Kona will be well and truly familiar with. So
Great, Gina, how about you?
So for me, when I was growing up, there were two things that really influenced me growing up. One of them was detective stories. I used to read them all the time, and I loved the idea of the detective always finding the clues. And as Kona said, the detective was the person with the answers. That's always was something that drove me. I wanted to find the answers to things. The second thing growing up that was really influential was I played a lot of team sports, and I just loved when the team worked well together. You know, you have a team, you each had your sort of, I played cricket. So everyone in cricket's kind of like baseball. Everyone has a specific role. And when it works, the team works really well, you win your games. It's such a good feeling. So that sort of, you know, detective stories and team sport, for me was influential, and I'll come back to that momentarily. But what really drew me to pathology when I was at medical school was the fact that I was really lucky in that we had a whole year course in pathology when I was a medical student, and we had about 8 hours, contact hours a week of pathology, which was just incredible. And we started every morning, I remember this, we started every morning in a Padua theater. So, you know, those theaters with those really steep sort of standing room only, and you look down on a table and the pathologist would come in and show a really interesting specimen from the week or the day before. And you'd look at a cirrhotic liver or an appendicitis or a tumor, and you would then sort of learn about the disease. And then the rest of the day you're in clinic and you would see patients with cirrhosis, with tumors, with these interesting diseases, with this picture in your mind of what it actually looks like on the inside, and a really good understanding and I guess appreciation of the basis of disease. And what is it that Osler says, the most famous Canadian pathologist, that as is your pathology, so is your practice. So if you really understand pathology, I think you get a really good understanding of the basis of human disease. So that was, to me, it was like an aha moment. And the other thing, I'm going to go back to what I started with. The pathologists, when we followed them around, and we used to sort of follow them during the day, I realized that here were the guys that had all the answers, and here were the guys that were all they played part of a team. They were always interacting with treatment teams in different parts of the hospital. So it's the ultimate, to me, it's the ultimate team sport, pathology. You get to interact, you get to help patients, and you really do provide answers. As Kona and Andy said, not all the time, but most of the time you provide the answers and you help patients get better. So I, like's been said before, I tried a bunch of things. I tried surgery, anesthesiology, OBGYN. My goodness, those nights were just never ending. Psychiatry, but I kept being pulled back to pathology because for me, that was the most important specialty in medicine.
Certainly is. I love hearing all the aha moments. Really, really wonderful. So we're going to move to the next question. And that is to Andy first. How has pathology changed since you started this career path?
Well, I think I would look at introduction of new diagnostic tools, I guess, as a way to summarize that. So back I was doing my residency between 1996 and 2000. And during that time, that was when immunohistochemical staining started really, to come into mainstream use in pathology to allowing pathologists to characterize tumors, particularly with respect to the site of origin, if it was a metastatic tumor, and various things of that nature. Prior to that, probably the new ancillary diagnostic test would have been, or diagnostic technology would have been, electron microscopy. Then from there, immunohistochemistry appeared. Then that was followed about, say, 10 years later by the emergence of molecular diagnostics and cytogenetics, and giving more, which plays a huge role today in terms of targeted therapies, personalized medicine, etc. And the list of biomarker testing seems to grow by the day. And that's one of the key roles of a pathologist, is to be a gatekeeper for the use of that testing and the responsible use of it. Then finally would have been roughly back in 2004 for me, but of late it's starting to catch on more and more, is digital pathology, and then the emergence of image analysis, artificial intelligence. And then hopefully before my career ends, we'll actually get into the realm of computational pathology, where you'll be able to take all of this data that I mentioned before, immunophenotypic data, molecular data, cytogenetic data, clinical outcome data, morphologic data from digital images, mash it all together, and then develop incredibly powerful predictive, prognostic, and diagnostic algorithms that will be able to mine information way beyond the pixels and go way beyond what pathologists can do with glass slides and a microscope. So I think those have been and people have used the term that, particularly with respect to digital pathology, that it's a revolution of pathology. And I don't think of it as a revolution. In fact, many people who have dabbled in digital path for for an extended period of time, just see it as an evolution. So those would be the changes I've seen.
Gino, how about you? How has pathology changed?
It has changed quite remarkably since I started training back in the mid-90s. I think for me, the biggest change is, and Andy alluded to this, is just the amount of information that we have available now from the tiniest pieces of tissue. We extract so much information from those tiny pieces of tissue. When I started training, basically a biopsy would be looked at under the microscope. You would do some stains, maybe look at some protein expression using immunohistochemistry, perhaps even do a real specialized molecular test, but only one, because he didn't have the techniques then. And that was it. Whereas now, you know, we've got so much information that we can get. You know, we've got the morphology, we've got the genomic data, the genes that are expressed, the proteins that are synthesized, the ultrastructure under electron microscopy. And that's available to us at a really short period of time. And I like Kona's comment before about this fire hose of information. That's kind of what it's like. You know, you get all this information, and I think as pathologists, it's our role to put that information into a concise, a relevant, and a helpful report for the clinicians, for the patient, so that treatments can then be decided upon, and the best treatment can be given to the patient. And that's why I think, for me, the biggest change is this information, and pathology has also moved much closer to treatment decision-making. And I think, you know, we are at a lot of these rounds now where we are presenting the pathology, but we're also talking about, okay, it expresses this gene, therefore this is the drug that you should use to treat this tumor. So I think there's much more of a blurring of boundaries between clinical medicine and pathology, just due to the amounts of information that we can give to the clinicians.
It is a fire hose, isn't it? Kona, how about you?
Well, I mean, I'm still fairly early on in my career. I think I've got at least another 20, maybe 25 years ahead of me. And, you know, for me, I just kind of grew up with the whole digital era. And so, you know, forensic pathology is even younger than I am. I mean, it's only been around for like 12 or 13 years in this country as a formal thing. And again, being at that really big brand new unit, there were two things that I just latched onto right away, which was, it's sort of the postmortem radiology, so postmortem imaging, and the molecular autopsy. And I just thought this was phenomenal. So the postmortem imaging for me, I mean, all of my patients, essentially, they all got full body CT scans, which was super helpful for me to not only figure out what was going on and get kind of like a sneak peek before I actually, you know, do my work. But it also helped me develop, okay, well, what are postmortem changes and how different does that look like in CT versus living people? Because again, I'd done a lot of radiology before. And so this to me was just an extra useful tool. And it allowed me to sort of target my autopsies. Like, okay, well, everything in the head is normal. So I can just target, like, I bet you anything it has to do with the heart or the lungs. And so that is sort of it's kind of this like merging of two specialties. And I almost wonder if, you know, postmortem imaging will become its own sort of thing. And the other one was the molecular autopsy. So like, you know, 20 years ago, if some young kid was running down a field playing, you know, football and suddenly dropped dead, chances are the pathology report would say, well, probably something cardiac, sudden cardiac death or something like that. But we didn't really know what it was. And so that still happens. But with molecular genetics and genomics, we can actually start looking at diseases of the heart at a molecular level. And that's extremely important. I mean, obviously it's always tragic when it happens to somebody, especially a young person, but that person or the results of that, you know, will get looked at. And then we have discussions with the family. So we actually talk to people. So we talk to the family and we're like, okay, you know, there is this variant. It could be transmitted through families. And so here is a referral to a heritable heart disease clinic, and you can choose to go get tested if you wish. And if they do carry it, they'll be followed for the rest of their lives. And if they don't, you know, then they don't have to worry. They don't have that worry for like 30 or 40 years that maybe that could happen to them. So, you know, with these types of things, and it's not just the heart, we're pushing out into other organs and other diseases. And with that, we may actually be preventing death, which, you know, might put me out of a job, but I'm busy enough. So I don't think that's going to happen anytime soon. But those kinds of things are so interesting. And I'm so excited to see what that's going to look like, you know, 10 years from now or 20 years from now.
Yeah, amazing. Amazing to hear all of your perspectives on this. So interesting. Next, back to Kona, and we all have our own academic interests and pursuits and goals. So the question is, on a day-to-day basis, how do you balance your clinical and academic activities?
Yeah, I'm one of those people that if I'm not doing something, if I get bored, I get into trouble. And all of my supervisors have always said that. They're like, just keep her busy, because if she's not busy, she gets into trouble. So for me, I'm just very efficient with how I do things. I get really, really good at my little area, and that allows me time to start exploring other things. And so, you know, my day-to-day practice, most of my cases are fairly straightforward. I mean, you know, drug overdoses, car crashes, natural versus tox death. Those are kind of like the basal cell carcinomas and tubular adenomas for pathologists. But the academic stuff, so I do have time to do some research. So right now, for example, I'm looking at how can we get quantitative toxicology results at the end of the autopsy, instead of having to wait for 3 months, which has huge implications for, you know, the criminal justice system and police. It also has implications for, you know, just trying to tracking things in real time. Like what are we actually seeing up here in Sudbury that might be very different from Toronto, or what potentially could be coming if we had this information, you know, 3 months ahead of time. But I think probably the most valuable thing to me is teaching, and that, you know, as busy as I am, that is something I make a priority for. I make the students a priority, because I think it's so important for them to have that. They do, because they come through, all NOSM students, so Northern Ontario School of Medicine, they all see an autopsy in person. I have them in small groups, and that's a requirement for them to graduate. And just having that one-on-one time with the staff is so rare when they're going through medical school. And, you know, for me, I say, you know, everything here is as hands-on as you want it to be. There's only one rule in my morgue: do not touch the sharp things. And all questions are open. It doesn't matter if they're about forensic pathology or medicine or what they saw on TV the night before. Everything is open for the students. And so making the time for that is really important. I still have time for other things. I'm, aside from my job, which I find absolutely fascinating, I'm horrifically boring at home. Like, I just, like, you know, I have my, like, I do some cooking, I've got my gardens, I got some chickens, I have my dogs. Like, that's really all I like to do. And so I guess it kind of balances out with how interesting my patients tend to be. They've got far more interesting lives than I do. And I do kind of get that sort of insight into, wow, geez, dude, what were you doing? That is, I've never seen that before. And so maintaining not just my sort of, you know, my practice balance, my academic balance, my teaching balance, and I'm also in leadership roles, which I do find, you know, stimulating on a mostly a mental level. I do find the sort of people managing or the issues managing quite a challenge, and to me, I just find it fun. But it is important to balance that other part of your life. And I think as pathologists, we actually do have that opportunity. We can, if we choose to, balance things out quite easily and quite well. And so there's a reason why pathologists, sometimes you see them, they're working into their like 70s and they still look great. I always say it's the formaldehyde, but I think it's the fact that we're happy, we're good at what we do, we enjoy what we do, and we have the time. I think that's important.
Kona, I don't think anyone could ever say that you are boring. Andy, how about you? How do you balance your clinical and academic activities?
Well, the time I spend on academic pursuits now has changed somewhat from moving from University Health Network to Mackenzie Health. I still am involved, and it's largely shifted away from things related to translational research more to spending more time on guideline development, particularly working with colleagues here at home and also with the College of American Pathologists to help prepare the specialty for the emergence of a whole variety of new tools. And there is a tremendous amount to be considered once as these tools start to emerge for routine diagnostic use. So most of my day is spent actually looking at digital images, or you can see there's still a microscope right here. So I do use it from time to time. It hasn't gone in the dumpster yet, and I don't think it will for quite a while. But most of it is spent doing diagnostics, and my scope of practice, of course, has expanded considerably now that I've moved out into something other than subspecialty practice. I still get consults from community pathologists who would send me cases when I was downtown at UHN. That's always interesting. I also spend time teaching residents. We will start to have some elective residents from U of T. I mean, being a relatively small department, we can't take, we certainly don't have a residence room and couldn't have 20 residents here at one period of time, at the same time. But we can have one person at a time, and usually we like to have them for about a month at a time, give them some exposure to the digital pathology. We try to pick senior residents so that it's easier for us and they can help us. And then they are also able to function more or less independently and work up cases, etc. And so it's with the electives that we have had so thus far, and they've come from other places other than U of T. Our first U of T resident will come in January. But the experience has been good both ways, both for the staff pathologist here and for the resident. So, and then I also do some remote teaching with residents at the University of West Indies in Jamaica. I've done that for several years. And it's amazing what you can do with digital slides, a slide sharing platform called Path Presenter and Microsoft Teams. You can run teaching sessions, virtual unknown sessions, just as if you were sitting around a multi-head microscope. And I love doing it. So that's a way of some outreach to a place where that doesn't have many of the resources that we take for granted here. And I've visited there many times. My wife is from Jamaica, and I've been also served as an external examiner for board exams at the University of West Indies. So I really do have a good idea of how much we take for granted here. And importantly, on the other side, how much can be done with limited resources if you you really put your mind to it. So those are sort of the major non-service work related pursuits that I'm involved in now. And balancing it it's always a chore. I mean, I've always found ever since I started at UHN that chronic overuse of the word yes can get you into a lot of trouble. You say yes to too many things and all of a sudden you're completely swamped. But I think we all do it with the best of intentions. And sometimes we're kicking ourselves like, why did I agree to do this? But once you've finished it, you know, you're very happy that you did, and you hope that you've been able to share information with others and that everyone benefits. The other thing important to me is having some sense of balance between work and the rest of my life. I have 3 kids. They're actually grown young adults now, all of them, and I love sports, running. My passion in particular is track and field growing up, so that's very important. I love to play golf, and I do put some pretty hard lines in the sand about personal time and involvement of things on weekends, so that I'm able to pursue those things, which really keep me as a well-rounded and happy person.
Gino, how about you?
Yeah, thanks, Anjelica. I think that's a really good question. Well, I think it's one of the best parts of pathology is combining your clinical and your academic activities and making it work. It's not, you know, something you got to work at. It's not easy, but it's so rewarding. And for me, a lot of my academic work that I've done, and I'll give 2 examples, but a lot of my academic work has been driven from what I've seen in my clinical work. And the first example is when I was a fellow, we used to get a lot of sarcomas, so pediatric tumors, really aggressive, really difficult to treat. And we had not many tools to diagnose them and provide the best treatment. So when I was a fellow, I got really interested in sarcomas and the ability to diagnose them more accurately, you know, provide maybe targets for treatment, get a diagnosis to the clinicians earlier so they can start treatment at a much better time for the child. And out of that grew, for me, probably 10, 12 years worth of really productive, rewarding and exciting research. And that was kind of driven from what I saw on the clinical side. The second part to the question is, or the second example, you know, what I've seen as a leader also drives my academic work. And I found when I was the president of the SPP back in 2020, it was during that awful time of racialized violence in the US, really came to a head with George Floyd. And we struggled a lot with what to do. And we put out a statement of solidarity, as did many other pathology societies. But what we ended up doing was we acted. We developed a grant looking at racial and social disparities and their role in child health and how best to rectify them. And for me, that was probably one of the best things I did in my role as president, you know, making real change, making sort of a grant available to address the issues in a small way, but nevertheless addressing those issues that we saw just engulf the world for those several months of, you know, incredible violence. So for me, what I do clinically, what I do as a leader really drives my academic work, and you have to make time for it. It's easy to just do clinical work because it's really interesting and I love it and it's lots of urgencies, but I think you have to have some sort of self-discipline and say, okay, you know what, for me to do this work, I find time. And you know what, if it's stuff that you really like doing, you do find time because it's that kind of flow you get into. You just love doing the stuff. And it's what gets you up in the morning to go into work, to do that academic stuff outside of your normal clinical work. So that's sort of my, I guess, concept of combining clinical and academic, and that little bit of discipline you need to make it work.
Yeah, there's many different ways to make it work, right? We just all have to find our own way. Okay, next question. So there's many things to be excited about in our field. Many of them you've all mentioned already that excite you personally. So how about more specifically, what excites you about the field of pathology? How about Andy first?
Well, I think the theme that's emerged as the 3 of us have been talking is just the information explosion, and then how we package that all up, mine it, and improve patient care, create opportunities, academic opportunities. And, you know, every time you seem to embark on a research project and you answer a few questions, you generate 50 more. And I think, you know, that it's just an endless list, I think, of possibilities now that we're in this information explosion era. And for me personally, as I mentioned, I think the most exciting thing is the prospect for computational pathology, which will allow, you know, all of this information that we see, the molecular, the clinical outcome, cytogenetics, morphologic, immunophenotypic, all the various omic databases that exist now. To put all of that information together and to start to see in certain instances that with simply a digital image of a hematoxylin and eosin slide, you can start mining out all that information just from within and beneath those pixels, to me is incredibly exciting. And there should be just a tremendous number of opportunities for academic careers for people going forward.
I see there's some questions in the chat about that, so maybe we'll come back to that shortly. Kona, how about you? What excites you the most about the future of pathology?
I think Andrew had it right, that the opportunities that are coming. Forensic pathology, like I said, is still really young, so there's so many questions, and there's so many things that haven't been answered yet that are just kind of sitting there waiting. It's a lot of fruit, and then things happen. So for me, for example, you know, my background is unique. My dad went to residential school. My mom went to, you know, to Indian day school. Like, I was not supposed to be here. Like, that was the whole point of that system, was to prevent me from actually existing. And I finished my training just as the Missing and Murdered Indigenous Women and Girls Inquiry started up. A big thing for me, because I'm thinking, oh my goodness, like what's going on in this country? But a new opportunity just kind of popped up. I had sort of toyed with the idea, wondering if anybody would ever look at what happened to the children, the people buried in these unmarked graves. And I talked about that with my anthropology colleagues, and we thought, you know what, if that ever came to be, we really should be ready for something like that. And then lo and behold, it's barely been a year, and this is starting to really move quickly. And so, you know, there was opportunities for me to sort of give my input, and I was totally just, you know, just as these are the realities of potential forensic investigation, and what are the possibilities, and more importantly, what are the limitations, and to just giving that information out there freely and on my own time, because people didn't really know what to do or what to make of any of this, or how this was going to happen. And that landed me a spot on the National Advisory Committee for this whole thing. So, you know, I'm just kind of sitting here going, okay, wow, I guess this is going to be like, this is my Jupiter. This is going to, I'm going to be doing this for another 20 years, because it's going to take at least that long to do this kind of work. So to have that opportunity, knowing where I came from, and knowing, you know, what my family and, you know, generations had gone through, in order for me to be able to do this, is just, it's very humbling. It's a little bit scary, but it's very exciting. And to me, I'm like, okay, well, this is something, finally, I'm like, Dad, like, look, dead people, yes, this is important. This is something that I can do, and I can actually contribute, and forensic pathology is sort of going to be center stage with these investigations. So those kinds of things happen. They still happen in pathology, and it's just, it made me really really appreciative that I actually went this route.
Amazing, Kona. And Gino, what excites you about the future of pathology?
Thanks so much, Anjelica. And again, a really good question, and lots of things excite me about the future of pathology, but I'm going to go down a slightly different path and say what really excites me is the shift in culture now of really wanting to look after our staff, our students, and our faculty. And a lot of that is, you've probably all heard the term wellness being thrown around, or well-being, but it's important. And as a leader in pathology over the last almost 10 years, I've just seen what happens when you don't look after your staff. And it is a responsibility of the individual a little bit, but the institution takes on a big responsibility for that. And I'm really excited about making changes that are for the betterment of our staff, our faculty, our students, and particularly with COVID. It's unprecedented, the struggles that healthcare workers, that students, learners, universities have been through. And I'm really excited about that. And I'll give you two real quick examples of where I see some of the future leading. One of them is what's called the 20% rule. If you do 20% of work that you find incredibly exciting, that you work at, and the time just flies by and you don't realize you've missed lunch, if you can do that 20% of the time, you have a 50% chance, you have a significantly lower chance of burnout than someone who doesn't do that 20% of the time. So that's a huge, like, it's one day a week, or, a couple of hours a day. You find that, you do it, much less chance of burnout. The second thing is what's called wellness-centered leadership. And wellness-centered leadership, simple concept, you put people first. And for me, that's so important. And that's what really excites me, not just about pathology, but leadership in healthcare.
Wow, amazing, insightful advice, Gino. We are almost at 6:30, so I think we will perhaps turn to the chat. And I saw there was a couple questions. I will direct this question to Andy to start, but I think Kona and Gino should give their perspective as well. So Andy, the question is, I guess I should say, we have a range of people in attendance, from students all the way up to experienced staff people. And if people in that spectrum, if they want to learn more about digital pathology or telepathology, gain training in it, for example, and they're just interested in learning more, what advice would you give them, or where would you direct them to do so?
Well, I think in terms of a starting point, I think, hopefully, we're at the point where more and more institutions will start implementing digital path for patient care. Many already have it in place for teaching and for research purposes. So there is that kind of baseline level of exposure in most academic centers. I think it's fair to say, would have at least one slide scanner. So people are, have ready exposure to digital images. And then seeing it for patient care, of course, the number of institutions that are using it on a day-to-day basis would be a bit smaller, but they do exist. And then the other thing that I've always found particularly valuable would be to attend conferences. And so there are a number of very digital pathology centric conferences that one can attend. And probably the best one, which actually just for the first time in its history, it started back in 2006, I believe, the Digital Pathology Association Visions meeting was held in Las Vegas in October. And it was completely sold out for the first time. They had, I think they had 700 spaces. And from what I've told, there were close to 900 people that they packed into the whole conference. And that, is a tremendous place for networking, to meet people that are at varying stages along, a digital pathology journey, from people, such as myself and others that have been working away at this for 15 to 20 years, and then others who are just starting out. And everybody brings their own perspective to digital pathology and how best to implement it for a variety of different purposes. And that's a fantastic opportunity. The presentations are top notch. The selection committee usually works very hard to pick very timely topics. So now there's a growing emphasis on machine learning, computational pathology development, et cetera. And so that type of one-stop shopping for 3 days, I don't think you can beat it. And you can really get an interest kindled there. And if you're a young pathologist working in an institution that is in the discerning phase for a digital path, I don't think you could beat it. You can really make some very valuable contacts to help with that implementation process. Of course, there are other things. You can join the Digital Pathology Association as a junior resident. You can join, as a junior member, rather, you can join things like the College of American Pathologists, which have a number of resources that are digitally based. You can apply to join committees. So each of the CAP committees that I've been involved with has at least one junior member who are residents, and they are encouraged to become very actively involved in all of the committee activities. So there are lots of those things around. And then, of course, if you have access to doing electives in places that have implemented digital for a variety of clinical applications. They could even be niche applications like what we did at UHN for years, which was just frozen sections between two hospitals, Toronto Western and Toronto General, and then supporting community hospitals in Central Ontario, in Timmins and Sault Ste. Marie, some primary diagnostic work with Lakeridge Health, and all of this was kind of taking place between sort of 2004 and 2016. So there are many places are using digital path for niche applications. So there's lots of opportunity.
Kona, what's your take on digital pathology and AI and forensics?
I was literally just like taking notes down as he was talking, because I'm like, oh, this is really good. Oh, I'm going to go check that out. So I'm like one of those people who's just at the beginning stages of even thinking about this. And for me, I'm one of those people that just, if I think something's going to work, or if I think something's going to really improve how, not only how I do my work, but how it affects the populations I serve, then I just jump right into that and I just latch onto it. So I don't have anything to say in terms of what do I think about it, because I don't know that much about it, but what am I going to do about it? Like I said, I just wrote down all that stuff. So thank you.
You're welcome.
Gino, how about you? What's your insight into this?
Digital pathology is incredibly powerful tool, and we are using it at Sick Kids for both internal cases, teaching, showing people frozen sections when people are off-site, and externally. We've set up a Canada-wide pediatric pathology digital consult network, and we get cases from across Canada, the institutions that they have challenges with, or they would like guidance, and it's literally sent to you in a blink of an eye. You can open the case, look at the slide on your computer screen, as Andy has said numerous times, and provide guidance. And sometimes you provide the full diagnosis, sometimes you just provide guidance with regards to how would you work this up, what other tests would you order, what kinds of things would you look for, what would you tell the clinicians. And that's something that I find it's incredibly exciting, because it brings the specialized knowledge that bigger hospitals have. Any big city academic center is going to have people who have this incredibly specialized knowledge that is just not available to smaller community hospitals. Smaller community hospitals deal with volumes of cases, and every now and again they'll need to reach out and ask for that sort of expertise, and that's available with digital pathology at the drop of a hat. What Andy's doing is transformational. It's bringing that specialized knowledge within the click of a button of people who need help with, you know, difficult cases. And we all need help with difficult cases. I can tell you, I've sent numerous cases to my colleagues in the US and across Canada where I'm stuck. So I think digital pathology has got a huge role to play in how we practice. And it's kind of breaking down all those barriers, like where we're all almost in the same office space now, virtually. So it's great.
Yeah, and Anjelica, if I can just expand on one point that Gino had made there, is I think in terms of community practice, I think we're starting to see that more and more junior pathologists who enter into community practice settings actually have 1 and in some cases 2 years worth of fellowship training in different areas. So they're bringing state-of-the-art expertise and training into these community centers. They don't necessarily have all of the resources that an academic center would have in terms of molecular diagnostics, cytogenetics, et cetera. But nonetheless, they have exposure to subspecialty practice. And I think what digital pathology does offer is the ability to create virtual communities of practice in subspecialty areas so that cases can be shown around in real time. And you know, I think can easily be argued that the best and safest pathology or best quality pathology comes from consensus diagnoses around different cases and getting different viewpoints. And I think that the digital technology and creating networks is a huge enabler of that. And then if you look also at just when you sit in an academic center, like I did for close to 20 years, the piles of consult cases can become considerable. And so you're trying to manage the work that you have for your own in-house cases, plus these fascinating consults that are coming at you from a variety of directions, and many of them just arrive unannounced. So you never know where the really important ones are or are not. And so if you do set up, you know, through digital path, if you can set up networks where you do have people with subspecialty training in a variety of areas, I think you can share these cases in real time and everyone gets better. And then you don't necessarily completely bombard the subspecialist who's sitting in an academic center when you don't necessarily have to send everything there. And then in terms of test utilization, I think there is a possibility to really effectively you know, be a gatekeep access to subspecialty pathology where specialized testing is absolutely required. And then some of the cases where you don't necessarily have to have that that specialized testing performed, that you can share that around in this virtual community of subspecialty practice. And I think, you know, this is something that we should really try.
Kona, question for you on digital pathology and AI. How do you envision or think that this could be incorporated into the forensic pathology world?
You know, one of the things that really jumped out at me was the ability to network across not just provincial borders, but international borders. And you know, expanding our forensic pathologists in this country are very highly sought after. And so that ability to transmit knowledge quickly like that, and not just for, you know, in between pathologists, but also with students and learners, and to be able to show like, hey, you know what, guys, this is what a COVID lung looks like in real time. And this is this has serious implications for what we're doing, and how are we going to, like, what are we seeing? Are you guys seeing the same thing? So when new diseases come out, to be able to see that rather than having somebody go across the world and travel, or, you know, waiting for tissue to cross international borders, and just that ability to have that expertise, and to have those people who, you know, have the resources and have the training and have that knowledge to be able to support others in countries where, you know, they don't have those resources, they don't have access to that, or those teachers, you know, in a way to globalize not just forensic pathology, but pathology in general. Like this, I think is going to completely change how we learn. It doesn't have to be, people are not going to have to go to, come to this country if they need to. I'm thinking maybe in the future, you can actually have training and centers of excellence in other countries to be able to share this information rather than, sort of keeping it in one area and making people leave their communities and leave their homes and their families. I think that's going to have huge implications in the next few decades.
Yeah, there's so many advantages, right? But I think, one that you mentioned, the digital training aspect, digital fellowships and such that we're seeing implemented, it's really, really powerful. Just to address one more small question about digital pathology. Again, we have people joining us that are from all different types of institutions, and for places that they don't really have a digital setup yet. The question is to each of you, to Dr. Evans first, what one-liner advice would you give them if they're looking to implement this?
I think first and foremost, the thing that I've seen, at least over the time that I've spent working in digital pathology, is you have to have a plan to implement it. So make sure that you've really identified a use case, a gap in your clinical service that you think can be filled by digital pathology. I think it's a big mistake to simply buy a scanner because everyone else is doing it. You really need to buy with purpose and intent, and then work towards the implementation of digital path for a specific goal. So for example, I mean, this was all serendipity, but during my time at UHN, the first application was neuropathology frozen sections between Toronto Western and Princess Margaret Toronto General. And what drove it was the consolidation of the department into a single site at Toronto General, and losing on-site presence in terms of pathologist presence at the Toronto Western site, but there's still the need to provide frozen section support. And then pathologists are either running back and forth on a shuttle bus all the time, or you can bring the slides to the pathologist virtually in a digital way. And so that was a very specific niche application that allowed us to focus on, ironing out some of the bugs in that system. And there are, every time you implement a disruptive technology, you have to expect to encounter some bumps in the road. So that's another kind of take-home point, is that patience and perseverance are very very valuable virtues when you embark on implementing anything that's disruptive. But returning to the point about just focusing, a focused application, once you develop it for one specific use case, it's much easier to start adding in others. And where I have seen things go sideways is if institutions figure they're going to start right from the get-go with digitizing everything and creating massive networks without really any experience in digital pathology, that things become very frustrating, and you end up making a whole bunch of people very unhappy, as opposed to starting with a niche application where you have a small number of hopefully willing participants that if anybody's going to be unhappy, it'll be just a small number of people, but for a short period of time, and everyone has a goal. So that would be my recommendation. Just implement with purpose.
Gino, any recommendations from you?
I agree with Andy. Two things. I agree with Andy that you need to find your purpose, and be that, do you want to build a totally digital workflow in your department? Probably not many people want to do that. Do you want it for external consults to open up the gates, so to speak, to external consults? Or, do you want it to help with coverage of subspecialty and specialty areas? We find that's been really useful for us. We only have certain pathologists doing some of the subspecialties, and if they're away, or if both of them are away at the same time, it's really good to know that they can still dial in, get the slides, and deal with those urgent cases. So A, find your need, and B, you got to find a clinical champion, because a pathologist saying, I need more tools, I need more toys, doesn't carry as much weight as if you've got a clinician or, you know, somebody in leadership or somebody who is on outside of pathology really gunning for you. I think that makes a big difference too.
Definitely. Kona, do you have any input on this?
I think those two gentlemen have said it all. I'm literally like sitting here. I keep taking notes. So thank you both for that.
Yeah, definitely such a wealth of knowledge on this topic, that's for sure. So we're going to move to the last question. And we would like to know from Kona first, what is one thing that you have learned on the job that your training did not prepare you for?
Oh boy, you know what? And I honestly think that this is, it probably affects all physicians. It's just, you know, all of a sudden now you have this mountain of student debt, especially, you know, for the ones that are going through now and the younger folks. And then how to manage that, and then how to manage life. And I mean, that's one of the things I always tell students when I'm talking with them, that, you know, I tell them what my salary is. I tell them how much I make. And that's so, you know, they're all like, oh my God, you know, my mom would kill me if I ever asked somebody how much they made. But that's so important for them to understand and to know, so that, you know, they can figure out, okay, well, what would fit with my financial goals and my financial health. So, I mean, when I was going through medical school, I mean, I have a corporation, I'm self-employed. I didn't know anything about that. I had no idea. So I kind of made my husband do it. So it really helps if you do have somebody who can. I'm still learning. But that training, all my training through all of that, and you're so focused on getting to the top of that mountain, and then you actually get there and you realize that a big chunk of it you don't really know what to do with. So for students and for learners and residents who are going through, it's probably a good idea to get a good financial advisor and really start learning before you have to tackle that mountain of student debt and you know, billings and corporations and all that business, because it really just does kind of hit you all at once. And, you know, planning for your future and planning for retirement as far out as that is going to be, you know, planning for how you're going to pay for education for children, what makes good financial sense to buy a house? Like, where should I buy a house in a market like this? Should I keep renting? Like, all of these questions, these financial questions that really play into how we practice, and then our personal lives too, is just, I felt completely unprepared for that when I started as a, you know, as a staff physician.
Yeah, probably all of us. Andy, how about you? What's something that you learned on the job, but that training didn't teach you?
I think first, I alluded to it earlier. I mean, the importance of avoiding chronic overuse of the word yes, which feeds back into just establishing your own priorities, and then recognizing you have to work with others. So you have to be a team player, as well as making sure that you take care of yourself. And then that great balancing act that unfolds from there, so that you cover all the bases. You have your family life. So if you have, you know, have children, like I'm blessed with having 3, as I mentioned earlier, and making sure I have time for them, have time for myself, for my own pursuits, and that my wife and I can enjoy things together as well, and that I can have a, you know, a rewarding career and hopefully do the best job that I can do in terms of patient care. That I think that's the great balancing act for me. And I don't think that my training necessarily prepared me for it. And I think most of us would probably say it's just something you feel your way through. It's particularly daunting when you first start, especially if you're working in a busy academic center where everyone identifies the new person and will have 10,000 different projects to funnel in your direction. So just prioritizing all of that and deciding what you like. I think Gino touched on it earlier, identifying what your passion is. And then if you can have that magic 20% of your time where you can work on that, and you're sort of more or less being paid to pursue your hobby, you're in a pretty sweet spot.
Gino, what's your one thing?
I think both Kona and Andy have said some really wise and interesting comments about that. It would be to look after yourself. I think there's a real culture in medicine that we're above the fray, we're superhuman, we're heroes. That term was used a lot a few years ago, and it's quite a loaded term. So, we are human. We do need to balance our lives. It's really important to find that balance between a really demanding and rewarding career in medicine, but it is demanding, and what you do outside of medicine, because you are so much more than your work. You know that, right? The other thing too is don't be afraid to have friends, confidants, mentors at work. They really do help. And without wanting to sound boring, it's been proven in studies that people who have close friends at work actually do a lot better on the burnout wellness scale than those who don't. So build those contacts. Don't be afraid to reach out. Yeah, I'm going to just end with balance and look after yourselves.
It's interesting hearing the answers, because I didn't hear anything about, oh, my training didn't teach me how to diagnose XYZ. It's all this other important stuff, right? That we have to keep in mind, and that is just so important for us. So we are approaching 7 o'clock. So I think it's a good time to end the session. So with that, I want to thank our 3 absolutely amazing panelists, and to everyone for attending the session and for the thoughtful questions that were submitted in advance and the questions that were asked in the chat. And the panelist group is going to do their best to address any remaining unanswered questions that were submitted in advance and get responses out to you by email. And we hope you enjoyed the session, and please look out for coming emails that are going to solicit your feedback and that are going to invite you to learn more about our programs, and finally for a copy of the recording. So thank you again, everyone.
Thank you. Good night, everyone.
Thank you. Good night.
Thanks, everyone. Bye.
Bye-bye.